think we have a member or two not in the room, so we'll keep that open. The vote is at 16-0. And as I mentioned earlier, moving through the bills numerically, AB 1603 is not going to be voted on today, but only for testimony, so we'll skip over it for now and go on to AB 1605, which is our health trailer bill. Ms. Costa.
Thank you, Mr. Chair. The Health Omnibus Trailer Bill provides various statutory changes, including provisions to implement federally required changes to pharmacy reimbursement, change the rate-setting methodology for PACE organizations, and other changes. Again, I'll highlight just a few of the proposals or a few of the provisions within this bill, and happy to answer any questions. Within the Health Omnibus Trailer Bill, we make the DHCS Long-Term Care Quality Assurance Fund continuously appropriated without regard to fiscal year. This is an issue that actually came up in the first bill that we heard, in which we provided an augmentation in the current year, and our hope is through the continuous appropriation, it'll take care of that. It's really kind of a technical issue. We also have included estate recovery within this bill, which would prohibit Medi-Cal estate recoveries except when required by the federal government. It results in general fund costs of approximately $5.7 million in 2016-17 and $28.9 million ongoing. Lastly, this bill includes the restoration of the acupuncture optional Medi-Cal benefit. It restores acupuncture services for adult beneficiaries effective July 1st, 2016, and it results in a general fund cost of $3.7 million in 2016-17 and $4.4 million annually thereafter. Happy to answer any questions.
Thank you. That's a quick overview. I know there's so much in here. We could spend a half hour just hearing.
There are many things I could highlight.
I know that. I'm not being critical at all. Allows the committee to focus in on issues of interest and question that we may have. Senator Stone.
Thank you, Mr. Chairman and members. I have some very strong concerns about the cuts to retail pharmacies, and let me just qualify my statements by saying that I do own a pharmacy, but I'm not a Medi-Cal provider, so there's no conflict of interest there. As we know, there is a new implementation of a federal standard, which I think is flawed, which reduces ingredient costs for many pharmacies and will actually take that cost at or below their acquisition costs. And most other states are responding by increasing the dispensing fee to make up for that loss. But as we know, in California, we have an ongoing study for dispensing fees that will not come to fruition until April of 17, which means that we're going to be asking many pharmacies to basically dispense Medi-Cal prescriptions at or below their costs. And this is a particular concern to older urbanized cities such as Los Angeles and San Francisco, where you don't have as many chain stores as you do smaller independent stores that are helping those that require those Medi-Cal services to exist. In fact, I've got a lot of pharmacies in my district that exclusively provide for the developmentally disabled communities that predominantly are on Medi-Cal. And so I'm concerned that you're going to have many pharmacies that are not going to have the access to care, especially in the urbanized area, and pushing those clients to some of the chain stores that may or may not fill the prescriptions at a loss as well. But certainly if you're a multi-billion-dollar company, you can weather those losses a lot easier than you can as small independents. And this might put the nail in the coffin for many of the small independents that have been calling my office and raising these strong concerns. So we had heard this in budget sub 3, and we had requested that the state entertain a 2007 study that would increase the dispensing fee by roughly $3, that the pharmacy industry said would carry them through for this year, albeit not as much as they would have liked, but at least it will keep these pharmacies on fumes and keep them alive until the true dispensing study comes back. So I wonder if the administration could respond to that, and is there any room to help the pharmacy industry out that provides these essential services, access to care to some of the poorer areas of the state?
Adam Dorsey, Department of Finance. So, we've met with you and with the pharmacies on this issue. We do acknowledge that the change in federal law has created a situation where the reimbursement rate will go down for a one-year period until this study is completed and a new rate methodology is in place. There is language in this trailer bill that will accommodate, in the Health Omnibus trailer bill, that will accommodate the creation of a new methodology once the study is completed. But in the interim, we didn't have a solution to the problem necessarily because the study that we had completed was too old under federal regulations to be of direct use to the state. But we will continue to monitor the situation along with the Department of Healthcare Services and try to make sure that we're ensuring access to the benefit for beneficiaries until a new methodology is in place.
And just to clarify one more time, the state is going to save by this acquisition cost decrease over $328 million. And we were looking to propose roughly $100 million of that $300 million that was basically taken from the pharmacies to allow them to continue to provide access to, namely the poor, those that depend on Medi-Cal services, particularly in the urban areas. And I would welcome some of the input of this committee to make sure, because I think once we adopt it, I think many of you will hear that represent the urban areas from the pharmacies saying it's difficult for us to continue to provide these services when we're losing money. We don't mind breaking even, which some of the pharmacies will tell you, but when it actually costs them money to provide services, and they provide services such as delivering to people's homes or giving immunizations, they're doing all kinds of wonderful services in the community, and we shouldn't expect any of our providers to work below their cost.
A point of clarification, the $328 million is a total funds number, and so the state share is about 130, and so that's the budgetary impact for the state.
Thank you, Senator Stone. All serious and real concerns. Appreciate that. We have Senators Wynn, Mitchell, and then Roth.
Thank you, Mr. Chairman. I wanted just to add to the comment from Senator Stone. I know not all bills are perfect. I would probably, for at least for my district, this is a 99.9% perfect. However, I do have a few concerns. The independent pharmacists, especially in minority communities, they depend on their pharmacists. That's who they know, they're comfortable with. And if, I fear that if any of these pharmacists decide to have to close their shops, that's where they're, they go for not only just picking up medication, it's to get advices as well. And so I hope that the administration would relook at that. I know that in last year has been something that's been very important to my district and to a lot of the children who are on Medi-Cal is DentaCal. In this budget proposal, we haven't restored the ongoing problems reimbursement rates of DentaCal. These children, it's very difficult to have to get a dental appointment if you're on DentaCal, especially for children. They're, a lot of times they're younger children. They tend to not like dentists. I think I have one, my 5-year-old likes the dentist, and my 3-year-old don't even want to come near it. So one is okay with it, one is fearful of it. And those who are the fearful one is the one that makes it very difficult. It becomes almost a specialist have to take care of them. And with the reimbursement that we have for DentaCal, you can't get enough dentists who will specialize in pediatric dentistry to help these children. And when we, did away with Healthy Families, that really impacted Medi-Cal, DentaCal for these children. And so I do hope that the administration would look at it again in the future, that we do look, one is the pharmacist independent. Please be mindful of the independent ones, especially in minority communities, and also the in communities that has just the local pharmacists and not the chain pharmacists. So it doesn't have, of course, more impact in minority communities because that's where those pharmacists are based, but there are communities, maybe the rural area, that has more independent pharmacists versus the chain. And second is the Dent-a-Cal for the children and the reimbursement for that. So thank you, Mr. Chairman.
Thank you, Senator Nguyen. Senator Mitchell.
Follow up on the administration's comment when you responded to Senator Stone, said that you would be tracking it. Does that mean that you'll be tracking potential pharmacy closures as an access issue? When you say tracking it, I just wanted to fully understand what you meant by that.
Oh, there we go. When back in some of the budget reductions in 2010 under AB 97 and the rate reductions, part of the agreement with the federal government when that was approved by the federal government was monitoring access to make sure that we were still providing the services that were promised under statute to beneficiary to eligible Medi-Cal beneficiaries. And so the process in place for that has been, not perfect, but consistent, I think, over time, where when we receive complaints about closures and access to care for beneficiaries, that those complaints are investigated, and the tremendous, erosion in the savings that the state experiences from those reductions over time have been related to the administration stepping back from those reductions when it was appropriate to ensure access to care, and that is still the policy of the administration, and it's still part of our agreement with the federal government, and what we'll continue to do, going forward, and until those rules are changed.
So as you received those complaints and that notice, is that ever shared with the legislature in any way? Do you collect that in any organized form? So in a year from now, would we know for a fact X number of pharmacies closed as a result of this policy, for example?
I don't know that we would know necessarily all of the numbers of the pharmacies that close, and part of that is just sort of the Department of Healthcare Services doesn't license facilities and license providers. There's a number of players that have roles in that, from, the medical board and others that oversee, providers to, OSHPD, which looks at hospital data and all of that sort of thing. And so there's lots of players in the healthcare delivery sort of, system for the state. But what the legislature does know is that when we have to undo part of the AB 97 reduction, as we did last year for dental providers in the budget last year, that part of the notification is a part of the budget process. At Jan 10, if we're going forward and proposing to unwind some part of that reduction, that is part of the notification of the governor's budget in January, at May, and at the Budget Act.
So getting back to your comment that you'll be tracking it, so what we will know based on your tracking is complaints from individuals about lack of access. That's the nature of the tracking.
Well, the complaints are, whether they come from beneficiaries or from providers, they are investigated, and we determine whether or not we're maintaining access, given the current rate structure. And that is sort of the process.
And what's the level of access that's acceptable to the administration, or is there one?
Well, it's changing. Right now we've got the federal Medicaid managed care regulations, and there was a budget change proposal that was part of the May revision in order to resource the department. Those have drastically changed the way that we have to look at how access is measured. And we'll have more, to say about what that is as we understand those regulations more.
Thank you.
Thank you for that clarification. Senator Roth and then Senator Bell.
Thank you, Mr. Chair. I'm trying to understand the rationale here. We're dealing with a vulnerable population in many cases, Medi-Cal. You can't force pharmacists and pharmacies to deliver a product at a loss. So some decide not to do it anymore. I'm concerned that with a vulnerable population, and by the way, this is an aspirin we're talking about. I assume in some cases the failure to receive the prescription and appropriately take it could be life-threatening or certainly health-threatening. So a person, a Medi-Cal recipient, can't find a pharmacy conveniently to obtain a prescription. My concern is they may not try anymore, and then they don't take their medicine. So I don't understand quite how you're going to monitor it effectively, efficiently, and timely so that you can then make an adjustment, a mid-course correction. I'll take your answer on the monitoring. Do you have the authority then to make a mid-course correction, and how fast can you do it if you find that people are not filling their prescriptions because they can't find a pharmacist conveniently to do it? If that's an intelligent question.
It is. It is a very good question, and I don't want to minimize the seriousness of the issue. I mean, we've acknowledged the impact to the industry, and have tried to, be responsive and have conversations about this, and try to, think creatively about how to solve the issue. I do want to put it in some perspective, though. As serious as it is, we do have nearly 80% of the population in managed care plans now, particularly people who aren't, cycling on and off the program or who aren't brand new to the program. They are in managed care plans, and this reduction does not affect managed care. So what we're talking about is the fee-for-service reimbursement. So I don't want to minimize the issue, but I also want to put it in perspective that this isn't affecting the majority of the Medi-Cal program. So that, that is one issue. And managed care plans are required to have, sufficient provider networks, and there's Knox-Keene rules around, and not every Medicaid plan has to have a Knox-Keene license, but, there are some agreed upon standards for sort of how managed care plans have to address this. And on the fee-for-service side, we take these complaints kind of as they come, and we try to investigate them and understand how serious they are in terms of the impact on the beneficiaries.
So in terms of monitoring, you're going to stay on top of it, and I guess if there seems to be a delta, even though the population is smaller, a delta between people who get prescriptions and those who are able to fill them, you'll come back with a supplemental appropriation request and we'll deal with it that way?
I apologize. That is the second part of your question. So yes, under our agreement with the federal government, we have the authority under our state plan to go back and adjust reimbursement rates. That does not affect the department's authority to spend, given their budget authority. And so if there's insufficient authority, this is why we come back with a supplemental appropriations bill, which unfortunately we've had to do several times over the last few years in the Medi-Cal program, to get authority to spend the additional dollars.
Okay, great. Well, I look forward to continuing to get an update on this, as I know my colleagues on both sides will do. Thanks. Thank you, Mr. Chair.
Thank you, Senator Roth. Senator Bell, and then Senator Pan.
Thank you, Mr. Chairman. I'm specifically interested in this mental health program for children. And first of all, can you explain that? It's a new thing. So it just came up recently. Is that true? And can you explain where that came from? It's kind of out of the blue a little bit for me.
Yes, so this was a legislative augmentation. This was not included in the governor's budget, and essentially this is 16 million general fund and 14 million from the mental health services fund to build facilities to provide services for mental health, substance use, and trauma-related services.
So it's the Mental Health Services Act.
Mental Health Services Act is the 14 million, and general fund is 16.
And what is it for?
So this will be, these will be grants. So it's a competitive grant program, and it'll be administered by the California Health Facilities Financing Authority. And local entities will be able to submit grant requests to the authority, and the authority will develop criteria to award grants for these, to build these types of facilities.
And, is it related to the audit that was done on school-based mental health services at all? And I don't know where this proposal came from. That's kind of what I want. I mean, I'm very interested in this whole subject, but it's kind of came out, and I never heard about it, so I'm kind of interested.
Teresa Calvert with Department of Finance. It is not related to the audit, but it is very much like SB 82 crisis grants, except these funds will be directed towards children under the age of 21 specifically.
SB 82 was in 2013. Those were the crisis intervention beds,
Correct.
the reduced recidivism.
And a lot, like mobile crisis teams out in the community, that's one component, but this is again geared towards children under the age of
So it's
21.
reducing recidivism for kids, or?
It's not specific to recidivism, it's more specific to just mental health crisis for children, and it's, again, administered by the,
Okay. Is it related to schools?
it's not specific to schools.
Okay, okay. And how much money was it? 30 million, you said?
3 total.
Sure, it's 16 million general fund, and then 14 million from the Mental Health Services Act funds.
Okay. All right. Well, I'd like to have more information about that because I've never heard about it, so.
Sure, we'll follow
I
up.
have there's no bill, is there a legislative
Didn't this come
proposal?
out of a working group?
Yeah, is there a bill, a legislative
There's
proposal?
been a lot of stakeholder interest, and I know the Mental Health Services Oversight and Accountability Commission has been looking into children's crisis, and so we've been hearing from various stakeholders. So I don't know that it's a new concept, but I don't know that it's linked to an existing bill per se.
Okay. All right. And what happened to the mental health programs in the schools, the audit, in response to the auditor? Was that included in the budget?
I'm not aware of anything in like the Oversight and Accountability Commission's budget particular to that.
Okay.
So we might have to follow up on that.
All right.
Senator Pan.
Oh, thank you so very much. I have a few questions, sort of follow up to some of the questions asked by actually Senator Mitchell and also Senator Stone. You know, in terms of the pharmacies, we know that NEHI, which is a health policy group, identified that at least in the whole country, medication noncompliance probably is a $450 billion missed opportunity for healthcare savings. So you usually say California is about 10% of the country is a rough, rule of thumb. So that's 45 billion. And of course, we talk about Medi-Cal. Medi-Cal is half of all children, a third of all adults. So that still sounds like a lot of money. So that's about 15 billion missed opportunity potentially if it's on the Medi-Cal program. So one of the questions I have in regards to monitoring, and I know that this is something I've had many conversations with the Department of Healthcare Services, but I guess I now have the opportunity to talk to the Department of Finance, is that what I hear is that what you're going to do is monitoring and wait for people to complain. And we're talking about population. I was a physician, I'm a physician. I take care of Medi-Cal patients. I took care of a lot of Medi-Cal patients. It's not the most empowered group of people. Often knowing who to complain to can be very confusing. Actually, it's interesting because you brought up managed care. So then the question is, do you complain to the plan or do you complain to DHCS? If you complain to the plan, will the plan actually tell DHCS you complained? Who do you complain to? So one thing I've certainly communicated to the department is that we really want to know what's going on. You can't wait for complaints. You have to be proactive. You actually call people and say, have you had a problem? Because people don't know who to complain to. They may complain. They may complain to their doctor. They'll show up back in my office and say, I couldn't get my medication filled. I couldn't find a pharmacist. Usually very few of them have ever told me as a result of that they have called up the Department of Healthcare Services or their plan to complain. They just simply weren't on their medication. And that actually can cost Medi-Cal even more in the long run. So I hope that whether it's pharmacy or dental or the myriad of other things in Medi-Cal, I hope that we will be more proactive in trying to ensure that people have access and not passive, waiting for someone to call us. Some people will, but it's not a very effective way of following up. The other issue, I guess, is also because we talk about rates, and there's a comment that was made that, well, actually we're 80% managed care, only 20% fee for service. This only affects fee for service. So I guess one question I have, perhaps for finance now instead of for healthcare services, I've been told repeatedly in terms of managed care, you establish the rates by negotiating a actuarially sound rate with a managed care organization. So is that actually sound rate based on the fee-for-service rates that you would pay for the various providers of Medi-Cal services? I mean, when you say actuarially sound, how do you determine actuarially sound? Is it based on the fact that you'll have a certain rate of utilization that is going to be paid at the rate in which we normally pay fee-for-service? Do you have an answer to that question?
So it depends on what type of data is available to the department when they're setting rates. Typically, it's the plan's experience that is used to set rates, but there are exceptions to that. And if you'd want more detail than that, I'd have to defer to DHCS and their rate setting folks.
Okay. So one of the things is that hopefully, I hope the members of this committee, as well as my, that actually, even though we say this only affects fee-for-service rates and 80% is Medi-Cal, is managed care, studies have shown that essentially the rates that are in the managed care are very similar to the fee-for-service rates. All right, and when you talk about, well, they base the historical blah, blah data, it's because we've always had low fee-for-service rates, and as we roll people into managed care, we continue to set our rates based on those kind of rates. And so I find it a little disingenuous to say, well, it only affects fee-for-service, so therefore on the Medi-Cal side, we don't need to worry about it, because it actually translates into the Medi-Cal side. So, so those rates are important, whether it's for, again, pharmacy or dental, which at least in my county here in Sacramento and LA are in managed care, or on the medical side as well. So I hope that we are more proactive at looking at some of those particular issues. And then finally, I guess, in terms of, and there's a lot of good things here, so I'm not all bad things, but I do have a question. I'm not sure where it falls into, whether it's in the health or so forth. So we are right now facing the possibility of Zika virus. So another, we have West Nile, we have Valley fever, we have and we have Zika. Some people are concerned, well, certainly it's the Gulf states that perhaps need to be most concerned, Florida, that, Southern California, probably not quite, maybe Sacramento's kind of the northern tip, but really it's San Diego, LA County. When it comes to response to, let's say, Zika virus, and unfortunately in the federal government, Congress has unfortunately not shown the ability to step up to the plate before this crisis gets worse. We'll see what they do in the next few weeks. What are we doing to prepare for Zika virus? I know we talked briefly with the Office of Emergency Services. They said that, so I'm not sure which part of the budget it falls into, but clearly, again, with a lot of people on Medi-Cal, it may impact the Medi-Cal budget as well. Can you maybe speak to our preparation for, or you can tell me it's in another bill and I should wait till then, but what are we doing to be sure that we're on top of that and the expenses that might be related to this outbreak?
That would be an area that would fall into the Department of Public Health, and so there's nothing in this trailer bill or in the 16-17 budget proposed specific to Zika. They have their infectious disease branch, a division over at Public Health, so we can follow up and get more information as to what procedures or plans they have in place for Zika virus. Most recently, we had federal funding coming in for the Ebola virus, and there is a number of funds coming into Public Health for that, but we can follow up and see what's in store on the Zika front. I don't have that information available today.
And if I may, Mr. Chair, I would note that there are a number of legislative augmentations specific to public health that were included as part of the final compromise, including funding for hepatitis testing and prevention, as well as Office of AIDS. But Zika was not one that was brought forward to us, but we'll be happy to follow up with additional information.
Appreciate it. I did note those augmentations. I appreciate those. That's why I wasn't sure whether it would fall into this or somewhere else. and that, again, when we had the measles outbreak last year, communicated with the Department of Public Health, that costs not only the state, but our localities, money, a significant amount of money. And so we want to be sure that we are ready as well in case, I know that we're well experienced with emergencies here in California, but I want to be sure that we're on top of that as well. Thank you.
Thank you, Senator Pan. It should also, on that subject, not go unstated that we've got a $2.5 million augmentation for early detection of Alzheimer's. Senator Stone.
Thank you, Mr. Chair, and I appreciate all the thoughtful comments with regard to this pharmacy issue. Opening up a pharmacy is not like opening up a candy shop. You got to go through a very comprehensive application with the State Board of Pharmacy. You have to get a DEA license. You have to get local licenses. If you compound, you need to get an additional license. And then the cost of fixtures, inventory, pharmacy software, you're looking at a $250,000 investment. And I can tell you that the trend today is seeing more chain stores opening and not more independent stores opening because the reimbursements for retail pharmacy have significantly declined over the years. And while I appreciate that there could be a supplemental allocation when these pharmacies begin to start closing, the problem is that once a pharmacy closes, they're done. They're going to liquidate their fixtures, and that access point for these very deserving people is going to not be available. And then you have to figure out the public transportation systems to get them to pharmacies that will continue to serve it. And remembering that these neighborhood pharmacies, many of them are multi-generational, that have been there for years, handed down from a grandfather to a son to a grandson. And these, the role of pharmacists has certainly changed over the years where, in a way, we've become kind of like the first line of attack when somebody has a problem, as many formerly prescription drugs are now available over the counter for us to kind of be first intervention for those that don't have time or don't have the ability to get to a doctor. In addition to now we give immunizations, we can do free blood pressure checks, emergency contraception. So it's important infrastructure, especially in these urbanized areas, and I worry that the supplemental allocation is going to come too late for many of these independent pharmacies that are going to close their doors, serving the most vulnerable of our populations in urban and as well as very rural areas where there's not enough population for the chain stores to open. So I hope that the Department of Finance and the governor will be open to continuing the discussion, meeting with many of the pharmacy groups that I imagine are going to be speaking today, and bringing the reality here today that if we adopt the budget as it is, it's not a matter of if an independent is going to close, it's a matter of how many are going to close and how many people are going to have a lack of access to care. And expanding on my good friend from Sacramento, my concern is that people are not going to remain compliant with their medications, and it could pose some life-threatening situations and certainly higher costs for us at emergency rooms that we've all been trying to work hard to mitigate. So, Mr. Chairman, I hope that there will be some openness to reconsidering this.
Thank you, Senator Stone. Just to underscore, there's never enough money to go around for all good things that we want to do. If there are no other comments from the committee, before we go see if there's any public comment on the health trailer bill, I thought maybe to end on a little higher note, to recognize that we've done a really good and important thing in the Medi-Cal estate recovery issue. So as we've heard through our subcommittee, and I think even through a policy bill that Senator Hernandez had authored, recognizing that Medi-Cal was actually taking low-income people's homes from them to repay the state back for the Medi-Cal provided during someone's illness, that has now been changed so that only those health care services required to be collected under federal law will be applied, and we will be keeping the equity of homes within the families that have built up that equity. So this is a real issue of fairness and equity in all sense of the word. So I think we can all be proud of that. Is there any public comment for the health trailer bill? If not, we have a motion by Senator Roth, and we will call the roll on AB 1605.
The motion is due pass. Leno?
Aye.
Nielsen?
No.
Allen? Anderson? Bell? Block? Glazer? Hancock? Mitchell? Monning? Morlock? Wynn? Pan? Pavley? Roth? Stone? Wolk?
The vote is 9-5. We'll put that on call with the other bills, which we'll leave open, given that we have members in committee presenting bills.